and I was really hiring to get a topic because the orthopedic general topic is to find the general topic is very difficult rather than the various fixation, dislocation, and so many the gadgematic. But finally, I thought of it's maybe common and also it's challenging and also a lot of unclear area. So aging spine. So then I discussed with him and they both agreed. So I'm going to discuss today effects of aging on spine. So here I'm not going to discuss whole spectrum of effects. It's not possible in this within our or this forum. Mainly I highlighted few areas, and also the selection of this topic. There are most of the specialties they handle spine, like surgical specialties, medical specialties, and even other various specialties. They need to be handled some extent, but their management is going to be overlap in the various aspects. Still, there are some debate, argument, and also maybe trial and errors. So it's not possible to clear everything. At the end, if there's any doubt, we can clear it out. So I'm going to touch upon some terminology because there are specific terms for the spinal pathology and the process of aging spine to some extent, related problems, not all, and condition related to the aging spine and various treatment approaches. So you can imagine the spine is, I'm not going to go for the basics. Spine is consists of 32 vertebrae, and the cervical 7, then thoracic 12, and the lumbar 5, and the 5-4. So they have a unique structure. They have a flexibility and rigidity, and also they move in the each vertebra in the different some control motion. So it's a unique structure. We need spine, but with the age or various other problem is going to be a troubling. So that's we are going to discuss in the next few minutes. Terminology wise, spondylolysis. Spondylolysis means chronic wear and tear spine. So these are common for the surgical and various other, just to highlight, especially medical students behind. Spondylolysis is mean the spinal fusion. So maybe various surgical or either natural. The ankylosis is usually we are quite common natural fusion of joint, especially in the knee, hips. So the fusion is ankylosis is very common, the wordings. And the spondylolisthesis. Listhesis means slip. Spondylo means always the vertebrae. The vertebral slip one or other. It could be in the top one is the direction front or either back. It's a listhesis or retrolisthesis. There are two terms, but the listhesis means slipping. And the spondylolysis. So lysis means some sort of a degeneration. I will show some pictures of past defect, especially there are areas the past vertebrae in the behind the your spinal cord. Spondylitis. Spondylitis means the inflammation. So itis is an inflammation of the vertebrae. It could be in the facet joint, could be in the vertebrae itself, or either some sort of a soft tissue around. And spondyloarthritis, inflammatory arthritis affecting the spine. So there are some more, but I highlighted what you need for this discussion. So it consists of 32 vertebrae, and if I show first picture, this is not clear actually. So it consists of 32 vertebrae, and also if you go into a medical school teaching or anatomy, so in the behind the spinous process, interspinous ligament, and the ligament of flavum, facet joint, and also anterior transverse ligament and the posterior longitudinal ligament. So these are the two structures. In addition to that, there are some the muscles, erect spine muscle. So all these will help to keep our spine erect. So every action is needed for various movement and keep your upright posture. So these are basic anatomy. I'm not going to touch too much. This is just to keep your eye opening. This is not the true picture. You can imagine here. So these are not one of the mouth, but this is how how aggressive. If you get these are the facet joint. So if you get a facet arthropathy or arthritis, so inflammation, there are a lot of the degenerative process and end up with osteophytes, and it's going to be impinging the nerve around from the foramina. So in the middle is the spinal cord. This is not the ideal, but just a picture I downloaded. So these are the normal anatomy and the normal joint of the facet. So usually it is a very flat joint, and slight movement is there. But if you get arthritis, damage the cartilage, and to prevent over movement is going to be osteophyte. Osteophyte is actually, though even it's a pathological, just to stabilize the problem. So it's a protective mechanism. So why need look into aging spine? So everybody knows the spine is, we need spine, and they protect our the spinal cord, and we need upright posture. So prevalence is increasing with age. So the problem is at the young age, you won't feel nothing, but with the age goes, maybe 60s, even 40s, sometimes even for the 30s, you can get hurt your back. So there are various reasons. So prevalence is getting increasing. The 60 to 85% lifetime chance of getting your back pain. I mean, even any individual, the chance of 80% get a back pain. These are not a degenerative, I mean just a back pain. So you can imagine how prevalence. Age in 35, about 30% show evidence of degenerative, either 1 or 2 vertebrae. So even in the 35, it's a very young age, you can get a degenerative process. So various reasons. And between 30 to 68, I'm almost 70% at the age of 65. At the age of 65, about 70% can get degenerative spinal problems. So you can imagine with the age going to be high. Two most problems we encounter day to day: the osteoarthritis, or either spondylosis, the other term, and the spinal stenosis. So both is diagnosis is challenging, and it's difficult to find the exact diagnostic model, but MRI is always there for us. But the two conditions are overlapping each other. So management also overlapping. So there's no clear-cut management. The osteoarthritis, this is the protocol, and spinal, but the management is overlapping. Many specialties manage back pain in their point of view. So that's fine. Some degenerative pathologies may be misleading. It's like if your eye is not trained to see the X-ray or either degenerative pathology process, you feel it's a fracture. So you need to be train your eyes for the normal anatomy and the normal bony architecture, and also in the pathological. Then only you can demarcate. Otherwise, it's going to be confusing. So imagine this kind of is an extreme. I mean, the severe degenerative osteoarthritis. You can do the anterior posterior view and the lateral. So diagnosis, both need AP and lateral X-rays. So usually standing, so it will give the more dramatic picture rather than the lying down. So if you want, you can ask for the standing. It's not possible for each and every station. Sometimes most of the station now do. So you can see in the AP X-ray. So these are osteophytes. So what are the features of osteoarthritis? There are 4 radiological features generally. You can see you can see the narrowing of the joint space. If I show a normal anatomy spine, that may be even better, but I couldn't find. So this is the narrowing joint space and the subchondral sclerosis. And also there could be a metaphyseal cyst, but here is not very clear picture, and also osteopathy. These are the four cardinal signs if you go for the X-ray to diagnose osteoarthritis, especially knee, hips, but it's the same as for the spine. And then the lateral X-ray, you can see the end plates. So end plates are the plate one above and one below. So it shows the end plate is damaged, especially in the tuberculosis and various other degenerative process. The end plate is going to be damaged. And the alignment, maybe coronal and sagittal alignment. So all these will give some idea of the pathology. But before go to the X-ray, always you need to be the excavate and you need to explore the clinical picture. Otherwise, it's not possible. So first thing is X-ray is very important rather than the jumping to the MRI or something sophisticated investigation. So what is the aging process? It's as I told, spine is a flexible and multi-segmental column. So it's a very useful structure for everybody. Without spine, sometimes life is not. I mean, there are spinal problem with the lying down in the bed. There almost no life, but spine is very important structure. Is functionally mainly protect the spinal cord just to refresh the function and anatomy and maintain the stability of upright posture and the provide mobility at the segment level. So it gives the wide range of mobility, flexion, extension, lateral rotation, and the various other movements. So all these movement is by various joints in the spine. So all these are very helpful for our day-to-day practice and also in the comfort. So first you should know what are the normal anatomy, then you can identify the abnormal. Degenerative process start in the disc. So that is the other cardinal thing. Generally degenerative process start in the disc. Usually I told the vertebrae and in between disc. This is the cushioning of the vertebrae, like a shock absorb in the vehicle. If you jump from a height, so we land into the heat. So maybe vertical shear pressure. So sometimes shock absorb in the various level. If it is a healthy disc, so that is a very early stage of degenerative process. So there are going to be various changes in the disc. So you can imagine it can be in the second decade. I mean, maybe 20s you can develop degenerative process, the various stages. Generally start with the biochemical. I mean, if it's a biochemical, sometimes you can't see or you can't feel, maybe change in the composition, maybe various oxidization in the disc level, and the change in the water contents. So all these are happening with the time. They're followed by macroscopic alteration. Macroscopic mean is going to be reduce the disc height, plus it's going to be, structure the annular ligament. So nucleus pulpus in the middle and around by the annular ligament. So it's going to rupture and going to be leak all the disc material and giving trouble. So everybody knows sciatica is a feature of sciatica, the disc prolapse. So next level is a facet joint changes. The facet joint, what I told show earlier, facet joint is a very subtle joint. It's a synovial joint. It's going to be early subtle movement, but if you get a abnormal movement due to collapsing of the disc, is going to be change in the various movement and start degeneration. So facet joint degeneration is secondary to the disc degeneration. It leads to subluxation and the osteophyte formation. What I told, osteophyte is a protective. I mean, if you have abnormal movement, just to minimize, they develop various osteophyte just to prevent the abnormal movement. So it's a body mechanism, but we are giving some side effects if you get a excessive osteophytes. associated with facet hypertrophy. If you get abnormal movement, it's going to be unhealthy and a disease facet. And thickening of the ligamentum flavum is next to the inside, surrounded by the spinal cord. Ligamentum flavum is a yellow thick structure. It's going to be various fatty changes and thickening, and leads to spinal canal stenosis. You know, generally spinal cord is transmitted to the spinal, the canal, so it's going to be thickened around the material, so it's going to be narrowing. So the then compression of the spinal cord, so that is called spinal canal stenosis. But if it is osteophytes impinging into the foramina is the area the nerve root is coming out from the either side, so that's causing radiculopathy. You can get a cervical radiculopathy, lumbar radiculopathies, depending on the site. And other thing is, just to highlight, usually radiculopathies and the compression and various other pathologies common in the cervical and lumbar. Why is that? Is quite mobile, but in the thoracic area is protected, and the fixed with the rib cage, the movement is very limited, so you won't get much problem in the thoracic vertebrae. But in the cervical and the lumbar is most mobile, so they get quicker than the other areas. So in advanced age, osteoporosis weakening the vertebral body, and it's going to be another changes. So with the age is going further, next level of osteoporosis. So osteoporosis, I'm not going to touch. Osteoporosis is a different topic, so it's going to be another hassle to the spinal cord and the vertebral column. Finally, aging leads to rotational scoliosis and the destabilization and rupture of the equilibrium. Equilibrium means we keep our head and the upper part of the body keep upright, various the antagonized muscle action. So in the flexor group and the extension group muscle. So it's going to be disturbed. So it's going to be various destabilization and the scoliosis, kyphosis, and so many changes come one after the other. It's a vicious cycle. So if you start degenerative process, various reasons, maybe this, then the facet joint and the vertebral body and the various other structures. So it's going to be a change in the normal structure and going to be a disease column. But most people dealing with the natural degenerative process without pain. So that is probably we do have some degenerative spine, but we don't feel pain. So that is a good sign of the degenerative aging. So, I mean, I told at the age of 65, 70% you can get the degenerative spine. So, but you won't feel pain. So that is a good sign. If pain present, so that called degenerative disc disease. So there's some, these are the various terms for the communication and the various the aspect they have given. Degenerative disc disease is a degenerative process with the pain. So that these are terms for the discussion. Right. So next, spondylolysis and spondylolisthesis. I told spondylolysis is some sort of a wear and tear effect in the spinal vertebrae and the joints. You can see these are just to, you can see here, spondylolysis is this is the past defect. So past defect is here. You can see in the top part there's some connection here. There's some bridge is already connected, but here's a defect. So there's a past defects. It could be either trauma, it could be degenerative, it could be malignancy, it could be congenital. There are various reasons. So we don't want to discuss further, but we are in the degenerative spine. Could be degenerative. Especially, just to highlight, yesterday also one patient came, especially pass bowlers. You know, pass bowlers and repetitive athletics. So they land on the one side and they turn the body. So they turn in body all the time, maybe 100 or 200 per session. So can get a stress fracture of the pars vertebrae, pars the area. So that is pass defect is very common for the professional pass bowlers. So then what will happen if you get damage that lock? So it's going to be slip. So spondylolisthesis. So it's like a cascade of event. So if you started, it's going to be something is going to be unpreventable. So it's a listhesis. So it's going to be various other sequelae. Just to refresh. And so what I'm going to touch upon some, especially this area, spinal stenosis, osteoarthritis, actually spondylosis, and the spinal curvature problem, kyphosis, scoliosis, and different deviation from the normal, the lordosis. Lordosis means the anterior curvature of the spine, the posterior curvature is a kyphosis. And diffuse idiopathic skeletal hyperostosis is another condition. It's not a pathological, but it's a inherited, can get even early 20s. And the flat back syndrome, the commonly missed and neglected. And the spondylitis is inflammation, everybody can understand. Osteoporosis, just to complete the slide, but I'm not going to discuss. And the disc degeneration is where I'm going to highlight few slides. The degenerative process could be either age, maybe due to various metabolic problems. So I'm not going to touch metabolic problem related degenerative condition. So before going to degenerative, what is red flag? So just to refresh, I mean, the people who are handling spine, so they may be aware and they will get used to red flags. Red flag is you are alarming the signs you need to know. Anybody handling spine or anybody treating the spinal condition or the back pain, you need to know red flags. Otherwise, you miss a lot. It's not common. It's a bit uncommon. But if you miss, it's going to be a very disaster outcome. So these are the few red flags for elderly, but there are some for the young. I'm not going to touch. It's going to be long list. If it is duration more than 6 weeks, it's going to be alarming your mind. You need to be keeping mind and investigate. And the age more than 50 with the back pain, again needed. And the past cancer, maybe prostate or either some sort of a cancer, past cancer treated, but still back pain, you can't keep neglected. And weight loss, night pain, fever, unremittent pain. So all these are constituent symptoms. You can't neglect. You can't wait for next month to see the patient giving painkillers, because these are very subtle thing. It could be totally normal, but these are the common things are always common. If you get these symptoms, chances are high. So weight loss, there are some definition. Night pain means usually you and me back pain, when you get a bed, when you rest, you're going to be improved. But in the pathological back pain or the dangerous back pain, it won't. So you can't keep quiet. Immunocompromised status, sometimes the pain will not highlight it. So you have to be look into more. And recent genital procedures, especially some sort of scope procedures, pressure, and there are some valvulus venous plexus, they can flush the infection and going to be various problem post-operatively. And pain worsening with the cough and sitting. So all these are maybe instability, maybe disc bulging, and sometimes various pathologies. You can't. You have to ask these questions at least. And the cord equina syndrome. I purposefully highlighted this very important slide. Cord equina syndrome is a dreaded. I mean, it's a very problematic syndrome. Syndrome is a collective of symptoms. So you can't miss, and you can't wait for more than 24 hours if you diagnose. Maximum maybe 48 hours. But if you wait for the next clinic, so end up with bladder bowel incontinence. Right? So how you are going to diagnose? Cord equina is it's a surgical or the medical emergency. You can't wait and you can't keep to see the next day. So usually the burning feeling. The other thing is that there's no cardinal symptoms, so either cardinal signs. So it's all the gather on suspicious. If you doubt, MRI. Burning feeling that can be constant or unbearable. It's a burning pain. So sometimes they feel it is gastritis and urinary tract problem. So, but that's fine. But always keep in mind possibility of codec pain. And the sensory loss range from the pins and needles and the complete numbness. They present with the pins and needle. They complain pins and needle in the groin area, sometimes in the back area. So these are vague symptoms. Sometimes some patients are not a good historian. So they just tell, and if possible, diagnose something like that. Some people are very good historians, so they will explain exactly what is. So it's very easy. So then get a saddle anesthesia. What is a saddle anesthesia? It's a typical feature of the Orthopaedic syndrome. Saddle is the harness we are putting onto the horse when you horse riding. So area where touch that inner thigh and the perineal area. So if it is numbness, no doubt, unless proven, otherwise the codec coina. And may affect the bladder, bowel, or either genital areas. It may be erectile dysfunction, reason, and various numbness. All these, they are vague. Weakness usually leg may lead to problem in the walking, sometimes shuffle walking, overflow incontinence. So bladder is full, there's no contraction, just flowing. So this overflow incontinence. When you put the catheter, you can drain more than 1,000 liters. So if the doubt, put the catheter, wait till fill the bag, you can get idea. And then the pre and post voidal bladder scan is a diagnostic to some extent. If it is post voidal, I mean, if you ask to void and get the bladder scan, if it is a retain the inside, if it more than 200 milliliters, they can't void. So that is a more suspicious of codec. The bladder contraction is affected. So then the guideline MRI. And this is a codec equina, it's a lower part of the spine. You can imagine the picture may not very clear, but here you can the spinal cord and the lower motor neuron and a lot of the spinal nerves coming down. So from the L1 down. So it's compression here. It could be in the disc, it could be in the tumor, it could be in infection, maybe trauma. So never know. Sometimes maybe spinal stenosis can worse all of a sudden. So anything possible, but you can't wait MRI or either transfer to area who can get the MRI. So other thing is the similar picture you can get conus medullaris syndrome. It's a more or less similar to codec equina syndrome, but in the conus medullaris you can get little bit upper motor neuron signs, but in the codec equina almost always lower motor neuron sign is below the spinal cord end, so below the L1. So it's more or less same, but the management is nothing different, as MRI is a diagnosis. There's no other imaging will help to exclude. Pathology is compression of the codec equina is a lower spine. I told already, early diagnosis and critical by clinical symptoms. So the other thing is don't get the idea. So you need to be MRI for the each and every back pain, but you need to be evaluate the clinical symptom and you have to challenge with your clinical knowledge, and then only you have to ask for the MRI. Otherwise, it's going to be another problem. Urgent MRI skin is mandatory. Otherwise, if you are not clearly understand the codec equina, you feel every back pain is codec equina. It's going to be a big problem. Prompt surgical decompression, preferably within 24 hours. So you can imagine it's the middle of the night, you have to do that. Either neurosurgically, orthopedic, or whatever the people who are doing, need to be decompressed. Otherwise, it's going to be a permanent lower motor neuron damage, so bladder and bowel incontinence. So it's going to be a maybe going to be sometime going to be sue, even medical legal problem. So can't keep the patient till you get the MRI and refer to place where the handle. Right. Now we come into the our main topic. I just want to highlight, because the back pain without knowing the red flag and the quad equina is not completed. So spondylosis could be cervical spondylosis, could be lumbar. So lumbar is common, cervical is though common, symptoms come very late. It's a common term for degenerative spinal condition. So everybody is familiar, spondylosis, something like that. It's a vague term, but it's most of the time is correct. It's a very common. It's a kind of osteoarthritis. 6 to 10% of general population. In the general is fairly high number. 25 to 60 in athletics. I told athletics people, so they have repetitive traumatic events, maybe high jump, long jump, and runners, and the other the team players. They have always they are impacting the disc and various other things. The chances is high. It's wear and tear of the cartilage, end plate, and facet joint. So I told imagine the anatomy. Could be cervical and lumbar. Diagnostic is challenge. I told diagnostic is, if you see the X-ray, if you are not trained your eyes, sometime after the lecture, every X-ray is like a lumbar spondylosis, right? So radiographic changes seen in all ages. I told in the even 20s. But we are not going to worry. Always the symptoms and tally with the investigation. And if you get something X-ray, you are not familiar, but there's no symptom, but it's get a second opinion. But we don't want to intervene. Even without trauma, young individual may show osteophytes. I told a high rate of asymptomatic degenerative individuals. So the giving osteophyte and having various radiographical changes, you can't label straight away spondylosis, or either you don't need to treat. So this is the generally weight distribution in the lumbar area. Right. So this is a normal vertebrae. This is some disease, normal disc. This is a disc with the some degenerative and the various changes. So generally weight distribution from the when you're standing, but 44% in the anterior column, and the middle column usually 48, and the posterior column generally very few, 8%, less than 10. So when you get a disease, so it's going to be reverse. The anterior column is going to be 19%, and the 41 and the 40%. So it's going to be almost upside down. So that is the reason. So get more and more pathologies in the back, especially in these are foramina, and also the spinal cord is going here. So this area are going to be more wear and tear in the, if you get disc started damage. So it's going to be more pathology, but anterior osteophyte, anterior lip lesion. So we don't want to worry unless some metabolic or some other reason, you won't get symptom. But if the posterior half and the posterior column, you will get symptom. So the thing is, if you want to keep this the distribution of weight correctly or either near normal, you need to keep your posture correctly and keep your dynamics and also the discipline correctly. Otherwise, there's no medicine. So this is another picture. So it will come maybe 2-3 slides after. So so again, it's a similar I discussed. So you can imagine how damage your spine with the subluxation, lateral scoliosis, various osteophytes, and lot of changes, and so these are everybody experience, but so you should know how to read it, how to assess the condition. And if you come down for further elaboration, you can see the diagrammatic picture, the bone spur is coming out with the disc, then you coming down. You can see the collapsing of the disc and the narrowing the disc space and going to be ankylosis. Sometimes bridging of the vertebrae and reduce the movement of in the two segments. It could be either ligament calcification, maybe anterior longitudinal, posterior longitudinal, ligament flavum, all these can calcify. Or either osteophyte can bridge and get a reduced movement. Sometimes if you get a sudden jerk movement, sometimes osteophyte can break, it's going to be a fracture. Osteophyte fracture can get pain for some time and then settle. So this is for a natural body mechanism to reduce the movement, because if you collapse this vertebrae, so abnormal movement. So this is to protective mechanism, natural protective mechanism, right? This is good for us, but if you get a extreme, going to be harm and problem. Initiate with the etiology, this pathology and the various other changes. This lesion leads to pathology changes the vertebral body and because it's a change in the alignment. Most osteophytes are anterior and lateral. There are three phases generally in the spondylosis. Dysfunction phase. Their function is going to be a problem in the when you get some pain when you're going to start walking. Sometimes when you walk for long, it's going to be hurt your back. Then the second stage is an instability phase. It's going to be, even you can't stand properly, it's going to be changed in a position, change like this. So it's difficult to stand still. It's the instability phase. And finally, stabilizing phase. It's like a 3 phases going to be stabilized. Various osteophytes, or either people sometimes they do braces and so many things. So again, to be stabilized. So initial dysfunction and the instability where you can get a lot of problem and day activities, and then the stabilize. The stabilize is not for ever, for the transient. And the degenerative process again mainly affect the vertebral body and the facet. That's called facet syndrome. Just I want to highlight few terms for you to get idea. So it's a narrowing of the foramina. I told it's going to be a problem in the nerve root and going to be radiculopathy develop. So maybe cervical radiculopathy, depending on the whatever the nerve root, you can say C5 or C6, whatever the symptom. If severe, cause pressure spinal cord and nerve root. If it is going to be severe, even it's compressed spinal cord rather than the nerves, leads to sensory and motor weakness. Sometimes it's going to be weakness of the lower motor neuron and even higher upper motor neuron, and cause paresthesia, imbalance, and muscle weakness. In the latter part of the stage, so we can't walk, shuffle walk, and the imbalance going to fall, and is kind of thing. And radiculopathy is a pain distribution of the myotome, and maybe sensory distribution of the dermatome. So radiculopathy is very important to demarcate where the problem. So if you get a radiculopathy in the C7, then you know the problem is here. At least you can narrow down your diagnosis, and you can quickly go into that area and get the X-ray or whatever treatment is easy. So that is the idea, radiculopathy, and the diagnose the myotome and the dermatomal distribution of the pathology. So management-wise, nothing, I mean, these are straightforward. Modifying, factors modifying, so like a lifestyle modification, and reduce body mass index, physical activities, keep your physical activity the correctly, and the smoking and alcohol. All these can cause the smoking and the alcohol is a poor healer, so they can get a problem in the disc and various other ligaments. So it's going to be more problem. The mainstay is treatment, the symptomatic management. So we don't touch for the surgical. Diagnosis key and the mainstay of symptomatic. So patient education. So once you diagnose, you have to pass a message, you are having this problem. Then patient psychological about 20%, maybe even more, pain will subside, because pain has a psychological component. So we have to attack for that at least for the initial phase. Otherwise, like a vicious cycle, is going to be not responding. Patient that's a cancer or something like that. It's going to be more pain. It's going to be something. The cycle is bigger. So the patient education. If you know the condition, you can ease out the problem. You don't have bad back. You have some degenerative problem. But treatment is long. You have to behave like this. You have to change your life pattern or something like that. The people respect, right? Need rest, not the bed, but it's kind of the practical way. And lifestyle modification, I told, it's depending on the individual. NSAID, obviously, there is a place. Physiotherapy, strengthening of the core muscles of the spine, and the rehabilitation. In the extreme age, you can't break, need rehabilitation. It's going to be a longer, maybe psychological or either physical. Surgery for management of complication, like, I mean, if it's a severe radiculopathy, you need the removal of the osteophyte and sometimes decompression. We do rarely, but there's a place. Base of treatment is symptomatic and adjustment of the life pattern and the regular follow-up and exclude various other pathologies, especially osteoporosis. I just get the myelopathy, though even can get a degenerative pathology due to DNA or either various other. Myelopathy is a compression of the spinal cord. It's less common, though it's very dreaded, but it's less common. Direct pressure on the spinal cord. If you get a spinal cord is like this, various material substance deposit in the surrounding spinal cord is going to be compressed. It's going to be myelopathy. So down tracts is going to be compressed and the blood supply is going to be compromised. So global weakness, gait dysfunction, and lost bladder bowel problems. So it's due to lack of blood flow to the spinal cord. When you walk, the demand is more, blood supplies need more. It's going to be a disability. So may elicit muscle spasticity, hyperreflexia. You need Nehammer, clonus. Hoffman is a pathognomic for the diagnosis of myelopathy. Brisk reflexes. Wonterberg sign. So it's if it is a cervical myelopathy, you can get if you straight. If you straight, your little finger is keep away. So that is a Wonterberg sign. So all these is not necessary to having all the patient, but at least if you get, that is more pathological. Vertebral bladder insufficiency, I'm not going to touch, just to show there is a problem in the compression. Then this is, you can see this X-ray, and probably you may encounter so many times. You feel that how bad and what to do, and it's going to be a last, the X-ray is not going to be improved. Yes, so this is called diffuse idiopathic skeletal hyperostosia. I mean, it's a kind of a excessive deposition of the calcium around the spine and the ligaments. So it's going to be look like a severe degenerative pathology of the spine, but it's not most of the time. Symptom is the equivocal, not comparatively to the X-ray. Commonly affect on spine, you can affect in the other joints as well. Condition cause pain, stiffness, and the reduced mobility. They can't, it's like a ankylosing spondylosis, it's a similar. So its flexion, rotation, extension is going to be restricted, stiffness. So management is not breaking or removing the osteophytes. So it's a physiotherapy, strengthening, and the medication and the meditation actually, and the surgery. Surgery if it is a severe case, just to complete. I mean, these are the, if you see the X-ray, if you don't get symptom, you don't have to be excited. Degenerative disc disease is 90% of disc problem is lowest part of lumbar. I mean the weight distribution, and the disc is large. When you coming down, it's going to be more insult. Though cervical disc disease is common, the symptom is come very late. It's a drying out, and it's end up with less water, less cushioning, less padding, and causing vertebral going to be harm. So healthy spine, 5 to 10% load. I skipped that picture I did explain. So disc pathology, degeneration is aging, right? Mainly the aging. 60 years show most of the degeneration in the disc. The obesity is other modifying risk factor, and the heavy lifting and the manual labor. Heavy lifting, I want to add the correct lifting. I mean, we do have to lift various object depending on your environment, but you will be correct posture maintained, right? You can't survive lifting or doing nothing. The family history is again there's a role, and the smoking is very important. So it's a nicotine may have toxic effect to the nucleus pulposus. So if it is a long-term smokers, they can attack the disc, so they can get more in the disc degeneration and the degenerative spine early. And the healing is also poor. And if you get a surgery, the poor healers, so all these factors, smoking cause more harm compared to the age. Basically, disc pathology, again, 4 stages, I will rush you. And dysfunction stage, I told the various biochemical, and dehydration, loss of water, because this is having 80% of water, and rest is mucopolysaccharide and various other substance. But if you get a aging, dehydration is more, and going to be the cushioning effect is less. And the third one, stabilization stage, and the collapsing. That's the last stage, where the two end plate is touching together. So degenerative scoliosis is other area where a lot of discussion, lot of argument. The management is challenged, and nowadays we are facing a lot of patient day to day, but sometimes it's difficult management, and the plan is not straightforward. Progressive and complex spine disease. Even in your X-ray, you can see some curve rather than the spondylosis. Sideway curve greater than 10 degree in adult, you can label as the degenerative scoliosis, right? I'm not going to discuss idiopathic scoliosis here. And the clinical presentation, 85% is axial back pain and localized to the convexity. Convexity means the convexity of the side of the back is pain is more. I want to get explain again the axial back pain. So if you get a back pain, you should know you can get the axial back pain and the spinal, the column back pain and the side back pain. I mean the muscle. The midline is a bony and the ligament structure. Sideway is a muscle, and you can get the back sprain. It's not related to the topic. Just for the general knowledge, back sprain is a spasm by the sprain of the muscle. You can get the back sprain. So these are treating it differently, and also I have noted so many even medical personnel, they miss diagnosis by the sacroiliitis. Sacroiliitis is so common. Sacroiliitis means the sacral joint. So the sacrum is joined into the two side pelvic bones. So there is a very common. Some people is overdiagnosis sacroiliitis. It's a bit of an unclear area, but I agree. But sacroiliitis is a very common symptoms you to diagnose. Always we label as a back pain, but it's not the true back problem. It's in the side. So sacroiliitis, about 30% is minor trauma. 30% is could be a urinary tract infection, maybe vaginal infection. All these are the common 30%. 30% is idiopathic, right? You can't find cause. So the disease area is lot of patient is wandering and going doctor shopping. But if you see if you examine correctly, there are two dimples in your back, in the side, the lower back. So area there, if you press, so you can get some pain. If you do in the couch and the Fleber test, the stress test to the sacroilius, they will get howling or severe pain. So that is sacroilius. If you see the X-ray, sometimes radiologists can they reported there's sclerosis around the two bones, the osteoarthritic changes, but it's made the clinical diagnosis. So it's quite missing. I just want to highlight because it's a very common symptom, because the day-to-day activity, they bend, they flex, and so many reasons they can get damage to the sacroiliac area. So the treatment is wise, if I say conservatively, the physiotherapy, medication, and sometimes we do injection, right? So poorly localized pain, I'm back to the scoliosis. So poorly localized pain and triggered by paraspinal muscle fatigue, because if you get a curve, one side muscle is going to be lax, other side is stretched, so it's going to be kind of a imbalance. Is need evaluation, right? The clinically, you need the history, the progression, how quick, and what are the what position you can get pain, or all these important for management point of view. Otherwise, every scoliosis we don't treat. General health, nutrition status, psychological aspect, and the level of disability. That is my personal, and also is very important. If it is not disabled, so you don't need to be intervention. You can do some treatment, but if it is disabled, you need the brain, and you have to think about what to do next. Specifically, you have to look for spine and the lower extremity and the vascular status of the lower extremity. All these are overlapping and poorly respond to the conservative treatment. Degenerative scoliosis not very well treated for the conservative, because it's a structural problem. It's always giving trouble. So I showed the X-ray. Coexisting lumbar kyphosis. The scoliosis associated with the scoliosis, I told the side way. Kyphosis is the sagittal way, bending forward. And degenerative scoliosis lead to flat back. So I purposefully flat back syndrome is again, people get not diagnosing, and sometimes is patient suffering. The flat back is a lower spine lost its normal curvature. Sometimes the lumbar is a lordosis. Sometimes flat is going to be problem in your back. So muscle, both spine, the back and the abdominal muscle is going to be hurt, because our spine, to keep the correct alignment, your abdominal muscle and the back muscle, both strength is needed. It's like a pulling in the rope. So it's going to be it's a sagittal imbalance. Sagittal mean the front back. Coronal is in the side, right? Coronal side. The sagittal is a front and back. So that's curvature. Difficulty in upright position. You can't keep like this, and the chronic pain and difficult to daily living. So to stand upright, they must contract muscle, back muscle, and possibly flex hip and knee. So you can imagine how difficult they want to keep. The maneuver temporarily help to stand upright, but over time maybe result pain. So they just stand like this, and like this. So kind of is keeping the both hips flexed to keep the straight. It's so hurting the spine, rather than spinal, and then the hip muscle and the hamstring. So this is a kind of you can imagine this is a normal curvatures. This is a normal shape of you can see the plumb line is going down to the hip joint, but here is a flat back. So it's going the front, right? And if you go more anatomic, you can see the picture. So we are treating for the back, but the problem starting or either maybe extending into the hip and knee. So we have to address for those structures. It's like the holistically. So other than the degenerative spine, the flat back may decompress and the fusion surgeries. And treatment-wise, physical therapy and gait and the posture training. Not only back, for the hip problem and the knee problem and various other structural problems need to be addressed, exercise and the painkiller, obviously. If fail conservatively, so corrective surgeries to improve the lumbar curve and the prevent worsening. So it's a generally kyphosis is, though degenerative, it's mainly due to osteoporosis. Osteoporosis, multiple wages is going to be stooping. So it's a treat for the osteoporosis. If it's a kyphosis, recent back pain, recent worsening, you can't wait, do the DEXA scan and see if there's any problem. Again, the scoliosis back, and these are the various x-rays and the diagnostic standard AP lateral, and to assess the stability and the rotational and the flexion stability, you can do the bending views this way and that way. So lateral bending views, whether it's slip in the vertebrae. If it is slipping, that's unstable. You can't manage considerably most of the time unless very feeble and old. And myelogram is, there's a place for the spinal compression, and DEXA scan for the to diagnosis of the pathology, and the sagittal balance and the coronal balance. I'll show you the pictures quick and easy. So this is a sagittal balance. I told in the if you see in the side X-ray scanogram, if you get side whole spine, you can see middle is this plumb line is going like this, the L5 and S1 vertebrae. But in the first one, is a positive that is going to be the anterior. So its plumb line is anterior to the sacrum, and the negative is the other way. So more. So it's a X-ray is needed to confirm the diagnosis, and the coronal balance is a lateral curvature, front back. So these are the various positive and negative. So I just want to show, because diagnosis is always challenging. We need some X-rays and investigation on suspicious. So treatment-wise goal, the strengthening. If it is if there's no instability, just a degenerative scoliosis, degenerative kyphosis, you need to be core strengthening, muscle strengthening, back and abdominal. Not only back, you have to ask for the physiotherapist strengthen the abdominal muscle. Both need to be strength to keep your spine correctly. And the gluteal muscle strengthening, and hamstring and the iliac psoas flexibility, all the stretching and the strengthening, improve cardiovascular endurance. So it's a kind of the package you need to be addressed. Every tick the box need to be addressed. Otherwise, it's a half job. And then the NSAID, there is a place, and the chiropractic, different treatment. We don't have here, but I don't know Colombo, but in other countries, they do spinal manipulation. So they have trained for spinal manipulation to correct the deformity to some extent and improve the trigger point. They do various dry needling to improve the muscle and the muscle knot. So they say muscle knot. If you get there are some knots develop, so they attack to that dry needling the muscle knot just to release. It's kind of acupuncture. So chiropractic is a different medical entity. It's not medical doctors, but they have trained for that. They have some anatomical and physiological idea of how to handle. But there are a lot of quacks in the chiropractic. Is very problematic. And a nerve root injection we do quite common, just a symptomatic relief, and by the time for the till you get the definitive treatment. So indication for the surgery, both scoliosis and the kyphosis, failing conservatively. So always almost conservative, I told, modification lifestyle, and patient, discuss with the patient what you need, and you have to address accordingly. Progressive leg pain, worsening leg pain and the new symptoms, you need to be addressed surgically. Muscle fatigue, secondary to spinal imbalance, you need to be correct the problem. Curve progression, if it is progression, need to be severe deformity, need to be addressed, because just for your knowledge, if it is a stooping of the thoracic kyphos, if you can't see about few meters, you need to be corrected. Otherwise, the far vision, you can't drive, you can't walk seen by very distance. So you have to address it. There's no place for conservative because the vision is very important. If you can't see few meters, then you have to do it some surgical correction. Otherwise, most of the time, conservative. Surgical option is repeating all the time. Decompression and decompression with posterior fusion, mean the surgical fusion with the screws, decompression with both anterior and posterior instrumentation fusion. I mean, depending on the stability, depending on the requirement, it's an assessment by the whoever the doing surgeon. So need to be addressed where the posterior element only or the posterior anterior graft or this. Hyperkyphosis is I told, is a age-related postural problem. Most of the people who get, most of the time is due to osteoporosis. That is called Davager's hump or the gibbous deformity. Is the bump is down here. So if you can see the curve, Davager's hump is in the upper thoracic area. Something like that. It's not a full curve. So they mainly due to hyperkyphosis, increase risk of fall and the fracture. They can fall and fracture, impaired mobility. Can develop due to muscle weakness. Sometimes the neuromuscular problem, you can get this flexion. And the degenerative disc already I told, and the vertebral fracture due to osteoporosis. There are multifactorial and maybe two or more pathology or either unexplainable pathology. It may be developed somatosensory disturbances, visual I told, and the vestibular dysfunction. So it's going to be imbalanced. So it's going to be a leading problem if it is kyphosis. They struggle to keep like this to see the far. So it's going to be hurt your back and various other problem. So management-wise, so many people try so many modalities. These are various postures to sleep, to keep the good alignment even in the night. And so many people try so many options. So this again more debatable. The taping in the left side, right side, and the brace in the left side. So brace is nowadays people commonly ask, is it possible to put a brace? So it's again, it's not going to be harm, but it's the outcome is not very satisfactory, and the studies wise not very conclusive. So the put in the brace, patient is happy, compliance is good, no harm, but the functionally and the outcome wise questionable, and people do tape. So this, but if it is considered fair, so our last option is fix with the screws, get the alignment correct and get the curvature correct, not 100%, maybe acceptable, and you have to fix with the screws and connect with the rods. These are rods and these are rods. So it's going to be, it's like a fusion. There's no movement at all, but we have to keep that some movement at the L5S1 junction at the the pelvis level. It's not going to be like something like this. You can bend, but the most mobile area we fix. Otherwise, it's going to be so many problem. And I just highlight the people ask for the brace. What your argument? So there are various braces commercially, pharmacy available, lumbar brace, thoracolumbar brace, so many brands, so many people wearing, but most of the time we are against, right? So because the brace, if you put a brace, the action of the muscle, both abdominal and the back muscle action, we are hand over to the brace, right? So they're going to be keep quiet. So if you remove the weight, if you wean the brace, you feel all the time you keep the brace. So in your patient, if you can't do anything, it's very fragile, you can't do anything, just a palliative braces option. But in the young patient, supposing back sprain, maybe transient problem, that is optional. But for the degenerative condition, if you put the brace, it's going to be a last treatment probably is going to be a wasting of your back muscle and going to be another problem, and it's like a lifelong brace. So this is kyphoplasty. It's a not new, but recently coming into the medical field. If you get a wedge fractures, you can see the various fractures due to osteoporotic. So we put there's some probe with the canal inside. So there's a balloon. Once you put in correctly under X-ray guidance, we inflate the balloon. We enlarge the vertebrae into the normal position, and we inject bone cement. It's a liquid, the more liquid form. It's go and deposit inside the vertebrae, because it's inside the vertebrae is almost a spongy bone. There's no strength to keep the two end plate in parallel. So we physically put bone cement and keep the end plate correctly. So for that, we need to be end plate intact. If it is an end plate damage, you can't do a kyphoplasty either, because if end plate damage is going to be leak and it's going to be damage the spinal cord. So always CT, make sure end plate is intact, then you can go for kyphoplasty, but expensive, and the price and the cost is highly problem. So management again, the kyphosis, physiotherapy, and various treatment like the first line. And the aim of treatment is to reduce the risk of fall, fracture, and the functional limitation. Anti-resorptive agent for wedge fractures, and the vertebroplasty, kyphoplasty for refractory pain. Some patient will come with even with the anti-resorptive, even with the painkillers, severe pain. That is due to structural problem, need to be addressed the kyphoplasty, the address the vertebroplasty, get the correct height. Therapeutic taping, questionable, and the early intervention may benefit. So if your patient is rapidly progressive, rather waiting for the last stage, go for the early intervention. Maybe the last few slides. Spinal stenosis is common, but maybe most of them undiagnosed. Right? Decrease tension of the ligament flavum. I told you the thickness is going to be high. Increase thickness and the remodeling at the in the spinal cord, folding of the ligament flavum, and the disc bulge also may lead to spinal stenosis and the osteoarthritis, rheumatoid, and so many condition. I don't want to address each and every. So you can imagine here. So this is the area spinal stenosis. So this is due to disc bulge, right? There may not be radiculopathy. There could be associated, but sometimes no radiculopathy. When you walk for longer, when you climb up, you can get a symptoms. So this demand is high. That area compression, that the perispinal vasculature is compromised. So you can get high demand. It's going to start pain. Sometimes you can get a neurogenic claudication. Neurogenic claudication is another symptoms, especially when you bend, it's going to be worse. I will show you next slide. Symptom-wise, the dull and ache back, and there may be spread to the leg, not necessarily. Numbness, pins and needles, calf, buttock, and that area. Weakness and balance is the worst case. Neurogenic claudication, and the decreased endurance to physical activity. They're reluctant to walk because they are always get pain. So we need to be exclude vascular pathology, vascular pain, but most of the time, maybe you can find the neurogenic causes. Treatment-wise, I don't think is anything interest. So these are various treatment for the spinal stenosis. This is a laminectomy. So there are two laminae in the either side, and the bridging the spinous process. These are the area we pass through the spinal needle, usually for the spinal surgeries. So we remove that part and keep the spine to be more healthy and more aeration and more circulate. So that is a laminectomy. It may be multi-level or either maybe facetectomy and so many modification, but need to be release the compression. And again, conservatively wise, obviously painkillers, facet block. If it is a some movement, we go into the facet joint and inject some dye and make sure your needle is inside the facet joint and release some steroid. Ideally under CT guidance, but even we can do under CM guidance in the theaters. Caudal injection, you can find the caudal space in the your lower part of the back. Is you can feel the dimple, inject spinal needle and dye and make sure Christmas tree and deliver your the magic drugs. And the braces is key for the discussion. And psychological support is very important, and social support, again, same. Rehabilitation program for the refractory cases. And when to operate. So again, more or less, I'll skip the time. And the newer surgical options, dynamic stabilization system, DSS. I mean, in the previous coleus, I saw the fixing screw and two rods. It's like a iron man is rigid, right? But it's a dynamize is important. You can see here. So these are the newer generation. So there's some movement is allowed at the rod. So the fix the screws into the pedicle into the body is fixed correctly, and then there's some movement here and movement here. So there's some slight movement, but alignment is maintained, but few movement is going to be preserved. So this is very good for the functional wise. The goal of any spinal surgery to decrease the pain, right? The correct spinal deformity and the improved stability. So these are our goals. Different technique and equipment utilize spinal surgeries, and traditional open and minimal invasive surgeries are still practiced. Older generation device, we use stiff rod, I told, and now newer generation is a dynamic stabilization device, very expensive and also not freely available, but it will come hopefully soon. So maybe the one before. So lifestyle medicine for addressing back pain, right? So these are not going to be discussed detail. So we have to address the nutrition. If it is a nutritionally good, so the pain threshold is more, and also in the healing and various other things is good. Exercise and physical activity is very important. You can't keep in the bed for the degenerative back. You need to encourage walking and various swimming, cycling. All these are not less impact to the back. So it's really encouraging for the dynamization of the spine. And the good sleep, good postural sleep and good mattress, because most of the time people use a lot of money for the sofa. For sometimes the bed using the most worst mattresses. But most of the time, rather than sofa, we are sitting on the bed. So we have to keep a very good mattresses for sleeping, good sleep, right? Stress resilience, substance use addiction, maybe alcohol or either the smoking, you need to be modified. Social connection, maybe interaction, similar patient and discussion, and the self-care. You need to be how to address your back. If you get back hurt, how to do minimize and how to get rid of, and so these are self-care is very important rather than going for doctors all the time, because if you go for the 10 doctors, you will get 10 advice. So it's going to be another problem for the end up with the psychiatrist, maybe 11th. So take home message, maintain good back discipline. So all the time, when you sit, when you walk, when you sleep, when you swim, when you drive, all the time, if you hurt, get the back seat in your car or whatever. You have to modify accordingly. Improve abdominal and paraspinal muscle strength all the time, maybe exercises. Keep good spinal dynamics. And most of the age spinal condition poorly responds to conservative options, but there's a initially very good place you need to be addressed first. First thing is always first. Exacerbation are common. Whatever you treat, they will come after 3 months, 2 months, maybe 1 month. So you don't have to depress. This is common. Intervention range from trigger point injections to surgical options. So start with the NSAID, various discussion, and the trigger injections, and the maybe surgical intervention. Chiropractic, I told the treatment play a major role, but still far away from us. So it's need to be, it will come soon. Thank you.
The forum is open for questions. So in the absence of any questions, I would like to thank our speaker today, Dr. Kapila Ranasinghe, for giving an informative, very detailed lecture on this topic. And also I would like to thank the sponsors today, the George Stewart Healthcare, for their generous sponsorship. To show our appreciation, I would like to call upon Dr. Janta Vijay Sekar to hand over the certificates to Dr. Kapila Ranasinghe. Thank you, madam. So that concludes our CMB today, and wish you a good day. Thank you. It's